Hi, I'm Dr. Donald Jurivich. I'm a professor of geriatrics at the University of North Dakota. Today, I'd like to present part 2 of our introduction to what we call age-friendly healthcare. And for further information and a copy of this presentation, you can go to the website over on the left-hand side here that says Dakota Geriatrics. So the goals today are to report the geriatric 4Ms, apply the 4M as assessments, and then create action plans for each of those 4Ms. I just wanted to point out that successful aging can often be identified with older adults, these two individuals being 100 years old, who actually look younger than their stated age. So as you recall, the 4Ms are a framework around what matters: medication, mentation, and mobility. Under the category of what matters, we want it to know what the older adult wishes in terms of their health care, and then we would like to align that healthcare plan with their wishes. In terms of medication, we try to avoid unsafe medications as much as possible. In terms of mentation or mind, we want to be on the constant lookout for dementia, depression, and delirium. And then finally, in mobility, we want two goals here. One is that we want to prevent falls. Falls have been increasing by almost 150% over the last 10 years in the older adult population. And we also want to make sure that the older adults have some sort of mobility plan, even if they're in a bedbound status. Just as a reminder that the 4Ms really do work and they improve the quality of healthcare. So we went over this last time, and I think the key feature here is that we reduce costs while increasing the quality by practicing these 4Ms on a regular basis. So the first M that we want to look at briefly is how to assess and manage medications. I think the key point is to recognize polypharmacy when it exists, and that's actually quite simple because if somebody is on 6 or more medications, they by definition will have polypharmacy. So with that medication list, we want to be able to identify which ones are unsafe or can lead to falls or can lead to delirium. As an example, a lot of people will take Tylenol PM for sleep at bedtime, and that particular medication has Benadryl, or diphenhydramine is the generic term, and those can predispose older adults to delirium if they get sick. So the final point here is that we want to use tools of assessment, and one of the best tools that I know of is the Beers list. And so you should at least be familiar with what the Beers list is and how to use it. In terms of managing unsafe medications, we firstly want to provide education materials to older adults and their family members. Maybe there's an antipsychotic that's being used that's really not working so well, and maybe just causing a lot of side effects. Older adults and their family members should know about that. Also, it's important as nursing and other allied health professionals recognize these medication problems, that they would consult with the pharmacist and as well as with the primary care provider. In any event, in the evaluation of medications, you might want to bring up concerns about too many medications or the existence of unsafe medications at team meetings or huddles. So when we talk about assessing and managing mind, we want to look at delirium. And so we can use tools such as the confusion assessment method or the New Desk tool. Keep in mind that altered mental status or delirium is most frequently hypoactive. That is, the older adult just lies in bed and isn't doing much of anything or shows a disinterest. Whereas a quarter of delirium episodes are hyperactive, and those are often recognized and easily recognized as we call the patient was bouncing off the walls. You know, they're acting a little hyper and just discombobulated. In terms of depression, we like to use a very quick screen called the PHQ-2. And if that is a screen positive, then we want to go on to the bigger test, which is called the PHQ-9. And the value of the PHQ-9 is that it helps identify treatment efficacy. In terms of dementia, various health systems have different types of screening materials, but I think the go-to test is called the Mini-Cog. It's 96% sensitive and specific. So it's a real good screening test where you ask 3 words, have the individual draw a clock, and then you ask them to recall the 3 words. If that is indicating with out of 5 points, if you score 2 points or less, then that's a positive screen, and you should move on and do the SLUMS test, which is a 30-point test, and that helps stage the level of dementia, whether it's mild, moderate, or severe. And then if it's severe score, you would want to then use the FAST score, which is a functional assessment test, to understand the point in time when the older adult with memory impairment is eligible for hospice care. Some of the action plans that are to be considered for the 4M of mind are listed here. So, for example, depression is often treated with medication and or psychologists for cognitive behavioral therapy. Sometimes a psychiatrist is involved in the care too, but it's basically multifactorial. In terms of cognitive impairment and dementia, we like to consider interventions such as cognitive stimulation, perhaps medications to delay the progression of the disease, certainly behavioral interventions when necessary, and then most importantly, caregiver training. In terms of delirium, the bottom line there is one has to find the cause, and it may be due to pain, urinary tract infection, pneumonia, low oxygen, substance withdrawal, whether it be alcohol or other, even medication withdrawal. There might be a biochemical disturbance reflected in the blood, such as a too high of a calcium level. So an important point or tidbit here is that the delirium or acute confusional state in older adults with dementia should be treated as if it's unresolved pain. And so giving them Tylenol or escalating the pain medication regimen would be indicated as a best practice. In terms of mobility, we want to assess fall risk, and that's done in multiple ways. Certainly history indicates a future fall risk if somebody has fallen or if they've had fear of falling. The tandem stance, where you put one foot in front of the other foot, and then you watch and see if they can hold that balance for 10 seconds. Of course, you have to be right at the side of the patient or the older adult to catch them if they get a little too wobbly. Gait speed is becoming an increasingly popular assessment, and individuals that walk less than 0.8 meters per second are considered high fall risk. Many may know about the timed up and go test, and we call it the TUG. In terms of the second component of mobility is that we want to assess whether there is actually a mobility plan with the older adult. So with that, we want to understand their readiness for change if they're not actively engaged in a mobility plan. So we want to understand their potential commitment to doing resistance, aerobic, and flexibility training. And then finally, just a word to the wise here. I highly recommend that all of us create our own mobility plan. And I have to share with you my own shortcoming is that I really hate resistance training. I love aerobic training, not resistance training. So I really got to make small incremental changes in my behavior to incorporate resistance training into my physical activity regimen or my own personal mobility plan. So some of the action plans for mobility include a fall risk individual, somebody that screens positive for a fall risk. Typically, you want to send them to a interdisciplinary fall prevention team. A lot of times those don't exist, and so you'd refer them to physical therapy. And importantly, if you do prescribe or refer to a physical therapist, make sure that you have a game plan for after the physical therapy is completed. Because often what happens is that the physical therapist sees the individual for 6 to 8 weeks, and then they discharge them from the service, and then the older adult doesn't really maintain any type of physical activity after that. Another key point, whether it's in long-term care or at the home setting, is to do an environmental safety check. Be particularly mindful of those transitions from carpeting to tile or smooth surfaces, which are often junctures of fall points. You also want to reflect on the medications that might be contributing to falls, and then also provide patient education materials such as the STEADY protocol from the Center for Disease Control, or CDC. Now, if an individual doesn't have a mobility plan, certainly patient education is important. You can provide them with a pamphlet from the National Institute on Aging chair exercise program and others. Just remember, resistance training is at the top of the list. We lose 1% of our muscle mass each year after the age of 60, and it's particularly accelerated in women compared to men. And then finally, if somebody is living in the community or is being discharged to the community from long-term care, a referral to community-based programs such as Stepping On are important for decreasing future falls. And here in North Dakota, I give an example of the website NDC3, which lists all the different community-based programs in the different communities in the state. So I'd like to summarize by saying that the geriatric 4Ms should include what matters: medication, mobility, and mind. You need to record those with each opportunity that you have an encounter with the older adult, and carry over some of that information if it's already been obtained. We have specific tools that we'll talk about that are used to assess each of the 4Ms. I gave some references to those earlier in this presentation. And then finally, we want to use those 4M assessments to create an action plan. And again, if it's a screen negative, we still want an action plan, because if somebody does have a mobility plan, then we want to review what that mobility plan might be and whether it contains all the different elements of physical activity, such as core balance, strength training, aerobics and endurance training, and then finally flexibility. And then finally, we want to use and document the 4Ms with each adult encounter, and we will provide some examples as how this is done or needs to be changed in medical record keeping as your particular healthcare system may identify, the either templates or otherwise for the documentation. So thank you for your attention. I look forward to our discussion about the individual geriatric 4Ms going forward.